Yeah. Good afternoon, colleagues. On behalf of the Pan American Health Organization, PAHO, I would like to warmly welcome all of you to today's webinar on advanced HIV disease. We're happy that you're here. This, as we all know, is an important topic. Despite the remarkable progress that we have been making globally and in the Caribbean, in HIV prevention, diagnosis, and treatment, advanced HIV disease continues to remain a major challenge, particularly in lower and middle income countries and in some of our own settings. Many patients still present late to care or return to care with severe immunosuppression, placing them at risk for life-threatening opportunistic infections and complications. Conditions like, such as cryptococcal meningitis, tuberculosis, disseminated histoplasmosis, severe bacterial infections, and Kaposi sarcoma continue to contribute significantly to HIV-related morbidity and mortality. However, with early recognition, appropriate screening, rapid initiation of treatment, and the application of the comprehensive advanced HIV disease package of care, many of these deaths are preventable. And so this afternoon, we're happy to have this session with you. We'll have initially a presentation, and this will be followed by a case study on advanced HIV disease. The poll should still be up. I encourage you to complete the poll. Keep working on the poll. We have a few questions. And while you do that, let me share a few housekeeping notes. So I think Mark did put a message in the chat. So do go ahead and type your names, address, your names, your profession, and your country. We will ensure that you receive the presentations of today's session via email. I'll ask that you please keep your cameras off and your microphones off. We'll take questions and comments at the end of the session, at which point you can raise your hand and open your microphone to speak, and we'll take those questions at that point. Please do continue to take the poll. We'll also administer another poll at the end of the session, so do stay with us. And you will also receive an email at the end with a very short survey, as we'd like to really gauge your experience of this webinar session. And so with that, again, let me say welcome to all of you. Welcome particularly also to all of the members of the advisory group of the Caribbean Community of Practice. And this is a session that's hosted by PAHO and the Caribbean Community of Practice. I see Dr. Omar Swed of PAHO. Welcome, Dr. Omar Swed. And I'm particularly pleased to welcome Dr. Jeffrey Edwards, who is the Medical Director of the Medical Research Foundation of Trinidad and Tobago. Thank you, Dr. Edwards, for supporting this afternoon's session. Mark, do you have an idea how we're doing with the poll?
Yes, so I believe here it says 11 out of the 80 participants that are connected today have been responding. Most have completed the first question, and the rest are making their ways through the remaining six questions of the poll.
Oh, wonderful. All right, so please do continue to respond to the poll questions. We will appreciate understanding the knowledge base that we have in the room, and I think this will give Dr. Stephen Symes a good understanding of how to, if necessary, to adapt his presentation as he goes along. With that,
Hello, good
yes.
afternoon. Where is the link for the poll? I only saw one question, which I answered.
Oh, Delcora?
I don't.
So with the poll, you should be able to scroll down from the screen.
It just said submit, which I did at the bottom.
Oh, because you were supposed to scroll. Apologies.
Yeah. Oh, then you submitted one response, Delcora. It's okay.
That means you got 1 out of the 7, right?
Exactly. That's why I'm concerned.
Oh,
And we're
it's not.
evaluating this by country. Watch out.
That's why I
Yeah,
asked for the link because I just realized it's one I answered. So and every time I wrote my name and I press enter to make space, I realized it's gone. So
it's
I
okay,
have registered a couple
Delcora.
times.
Not a problem, my dear. Yes. So for others who are still on the poll, just keep scrolling down until you get to the end, to the very last question, okay? And just a kind reminder to keep your microphones off. Thank you very much. So while you continue to respond to the poll, let me go ahead and introduce Dr. Stephen Symes. I hope I'm correct calling your second name correct, Dr. Stephen. He is an associate professor of medicine, Division of Infectious Diseases with the Miller School of Medicine. He completed his medical education at Howard University in 1989, an internal medicine residency at Jackson Memorial Medical Center in 1992. With main clinical activities in HIV and AIDS, Dr. Stephen developed pathways to train future physician leaders in global and domestic health programs, administration, and advocacy. Dr. Stephen has served in institutional undergraduate medical education and graduate medical education leadership. As Associate Dean, he founded the Office of Community Engagement at Miller, emphasizing workforce development. With medical students at Miller School, he started a human rights clinic for asylum seekers who are victims of torture and abuse. Dr. Stephen also served as primary care physician in Thrive, a University of Miami Jackson Memorial Hospital clinic for victims of human trafficking in South Florida. Dr. Stevens is the medical director at the community-based Center for Haitian Studies, providing care to uninsured patients in North Miami community. He continues to be actively involved in medical education. With Miller School supervising pipeline programs for aspiring pre-med applicants, faculty mentor for MPH, MD, MPH students, faculty advisor for Student National Medical Association, executive member of the Admissions Committee, I'm sorry. And with the Center for Haitian Studies, he's directing clinical clerkship for students from several of our Caribbean medical schools at Jackson Memorial Hospital and community-based sites. So quite an extensive experience and tremendous work with our Caribbean community. And so, Dr. Stephen, I take the opportunity of saying thanks to you for your time, taking your time from your busy schedule, putting together your presentation to deliver to us this afternoon. You can go ahead and start sharing your slides. I don't know if you can, but the poll is still up. Okay, wonderful. So maybe we can get started. Yes.
All right, so hopefully everyone can see the slides and welcome. I'm glad to have all of you joining. I know for many of you it's lunch hour and I really appreciate you spending the time listening to this talk. So I'm going to talk a little bit about advanced HIV disease, just a little bit about diagnosis, treatment, and management. I got a wonderful summary document that was put out in 2025 by the WHO that emphasize the importance of this. Here are some of the objectives we're going to try and cover. How do you diagnose advanced HIV disease, including the concept of packaged care, which is, I think, a code for having a support system around you, right? Whether it's social work, case managers, community outreach workers, but pharmacists, but people that can really help you as practicing providers do the best that you can for your patients. How do you treat initially and when to treat? Some special conditions, opportunistic infections and illnesses such as cryptococcus, histo, TB, and KS, and some special considerations related to inflammatory response syndrome, the things that your specialists will call you or your hospitalists will call you saying, what the hell is going on? Why is the patient going down the tubes? And then you're there to try and reassure them that, you know what, it's not so bad. We can manage and we can take care of this. So I'm going to start off just talking a little bit about this idea of um, advanced disease. And WHO has really tried to give a clinical staging from asymptomatic to severe disease. And all of us who've practiced and taken care of HIV, patients, we know what severe disease is, right? We know about the patients who present with AIDS, with Candida esophagitis, or TB, or pneumocystis jirovecii pneumonia. But it's worthwhile keeping in mind that patients can also have mild disease, right? When they present. Classically, herpes zoster is one of those warning signs that tell you, you know what, there may be something wrong with the immune system, especially when you're seeing it in a younger patient. And then moderate disease that we also see sometimes. So the staging system is actually, you wonder, has it been supplanted by our use of our, lab tests such as T cells and so on that helps to quantify, how bad the immune system is. And I would say yes and no, right? So certainly when you look at the CDC case definition, it's a T cell count of 200 or less that qualifies patients with AIDS, or a CD4 count percentage that's less than 14%, because we know that the absolute T cell count can vary widely. You may have had patients in your clinic who have had HTLV1 infection, or, and they have these huge T cell counts and yet they're clinically not doing well. So again, we also have to be a bit cautious about just using the T cells to quantify patients. So again, WHO recently came up with this idea of advanced HIV. They're trying to maybe go in a little bit more of the direction of the CDC and say, let's use our T cell counts for older kids, adolescents, and adults to say this patient has advanced disease, as opposed to waiting to say, okay, the clinical stage in which may be off or not. And I think, again, that's useful when you have rapid T cell counts available and accurate, but there are some caveats, and I hope the case helps us a little bit to illustrate that. So first case here we have is a 35-year-old woman who comes to the emergency department. She has fever, she has pain on swallowing, weight loss. Her HIV test was negative a year ago, but her current rapid test in the emergency department is positive. She does not respond to oral or IV fluconazole at 200 milligrams daily, much to the dismay of everyone. She's still having severe pain. And so you get your GI consultant to do an endoscopy, and he finds a couple of very deep ulcers in the esophagus, which on biopsy the next week is negative for CMV, HSV, negative for fungus, and no malignancy. In the meantime, you've gotten your T cell counts back. The T cell count is 340 or 16%, and the viral load is 1.4 million copies. So my question to the audience, and again, you can, type in the chat if you want, does she have AIDS? And be sure before you answer the question, does this patient have AIDS? Maybe a little bit of an easier answer, does she have advanced HIV disease? And then last, if you want to take a swing on it, how would you treat? What medication? It's a week into the hospital stay. She's had she's had upper endoscopy, biopsy, and still can't swallow. And everybody's starting to get a little bit antsy now because we're not making any progress. So what would you do next? You have the data to make a decision. Now you have to make a decision. So quickly again, just talking about pathogenesis of HIV. I'm scrolling through my chat just to see if anyone brave souls have taken a swing at the ball. No one yet. HIV, this is an electron micrograph of a T cell, and HIV surrounding in red, the virus surrounding that T cell, binding to those CD4 receptors. And then later in the cycle, you can see in blue, another electron micrograph, those mini baby HIV virions budding off and going off to attack other T cells. And as time goes on, these virus producing factories get worn out, they get depleted, they die, less and less T cells, more and more virus. And we've all seen this kind of pictograph. I saw this all the way back in my residency, right? From primary HIV infection, where you're first exposed, it's an acute viral illness with adenopathy, rash, feeling, ill, fever. And then there's that period of what we call clinical latency, but there's still a drop in T cells at a rate of about 60 to 80 per year. And so classically, again, you get that idea of going from a normal T cell count of about 1,000 down to less than 200 over about 7 years, 7 to 10 years at that rate, right? But we also know that that sort of idea of what we had of that classic progression, it doesn't operate for everyone, right? Those are your typical progressors. But you also have people who have tested HIV negative, and then a year and a half later, they have full-blown AIDS, your so-called rapid progressors, right? Their immune systems seem to be particularly susceptible to HIV. And we know about non-progressors also, about 4%, 3% of all of those who are HIV positive who are infected test HIV positive, but their T cells never drop, and you can never really pick up any viral detection, viral load in their bloodstream. And nowadays we call these either elite controllers or viremic controllers, depending on how well they're able to control HIV replication. So again, there's this mix and match of different progressions, not dissimilar to other types of viral illnesses that we've seen. We see all that with COVID, right? That some people get really, really sick and crash and burn, and others who are completely asymptomatic. So same thing with the flu and other viral illnesses. So we shouldn't be too surprised that this also happens with HIV. So back to our case, our 35-year-old woman with the fever and difficulty swallowing and weight loss with a negative HIV test a year ago, but now her rapid HIV test and the confirmatory test is now positive. No response to diflucan. She has a couple of single deep ulcers that are negative on biopsy for pretty much everything. May also have some oral ulcerations. A T cell count that's not quite less than 200 and not less than 14%, but a very high viral load. So, does she have HIV? Yes. Does she have AIDS? Probably not, right? Does she have advanced HIV? Definitely, right? So this is not a mild case, right? And how would you treat? Just keeping my eye on the chat, see if I get any brave takers here. None yet. All right. So this is what we would call idiopathic esophageal ulceration. Again, we see it not that often. I looked at the list of AIDS-defining illnesses again to see if it popped up, and I couldn't find it, right? So where you diagnose AIDS, first of all, do you have an AIDS-defining illness? Doesn't matter what your T cell count is, and this patient doesn't have that. Is she really sick? Yes, she is. She's really sick. She's ill. She's in the hospital, can't eat, can't swallow. Why did she go from HIV negative a year ago to HIV positive now? Well, she probably is what we would call a rapid progressor, right? She's one of those people, again, who go from, really, really negative to acquiring the virus and going down the tubes very, very quickly. Or the other possibility is she's going through acute retroviral syndrome. And we know that some people who go through acute retroviral syndrome have lots and lots of symptoms, all the way to having, sometimes opportunistic infections. So that would be the right answer. She's either a rapid progressor or she's going through acute retroviral syndrome. it doesn't matter, right? She is sick. She has what we call advanced HIV disease. And I think this is what the individuals at WHO are trying to get at, right? Is that you can try and use clinical staging to say, yes, this has a patient with advanced HIV and all hands on deck, or you can use your CD4 count, which indicates a severe depletion in the immune system. But in either case, you do need to act fast and you need to be very careful with these patients because they'll do very poorly if you don't, right? So I think most of the people on this call do have access to CD4 testing, and can get it back pretty quickly, usually within a day or two. And even in our hospital at Jackson, a major referral center, it takes us a couple days to get the T cell count back. There are rapid CD4 testing kits and processes available. They'll tell you, is it less than 200 versus not? The nuances there are that you need to also have some standardized ability to be able to, make sure that what you're doing is accurate. So you have to have a quality assurance process in place to make sure those rapid tests, CD4 tests are accurate. And then the last thing WHO is saying is that in addition to making the call, which is what you as professionals are doing, you do need to have some kind of package intervention in place to make sure that you do things like getting started on prophylaxis, rapid heart, and adherence counseling and support, right? So that's actually been shown to really make a big difference in outcomes, as opposed to, your ID expert or your HIV practitioner who knows what they're doing, but doesn't have time to run around and call, 50 people every day to make sure that they're taking their medicines or to problem solve issues with pharmacy, drug interactions, adherence counseling, bipolar disease, intercurrent interactions with medications, and so on and so forth. So our next big question, when to start antiretrovirals in HIV patients, especially hospitalized, as in this patient. And she does need to start heart, but remember she can't swallow, right? That's actually really important. And our ART regimens are all oral for the most part, as they should be. So that other question that I asked you about our patient, what would you give? It's steroids, right? You'd want to give IV steroids for aphthous or idiopathic esophageal ulcers, especially when patients can't eat. Usually about 1 milligram per kilogram, IV at first, and then PO very quickly. But as soon as they can swallow, for a patient like this, I would want to get them on an antiretroviral therapy regimen, especially if that can be continued as an outpatient. So the limits are, if at your institution, you can start it inpatient, but you're not sure if they're going to make it to the pharmacy and continue as an outpatient because the paperwork isn't in, then maybe, you might want to wait until they get to the clinic. There are some absolute indications here in purple when there's nothing else that's going to work. So if you have a patient with cryptosporidiosis or microsporidiosis who's having diarrhea like you wouldn't believe, right? Secretory diarrhea, massive. The electrolytes look terrible. The potassium is 1.5. You can't measure the magnesium. They're volume depleted. Guess what? That patient, you need to start them on antiretrovirals. You have to get them under control. You have to get the immune system at least partially responsive so that they can start eating. Same thing with PML, progressive multifocal leukoencephalopathy. We do not have good treatment except antiretroviral therapy. Same thing for AIDS dementia. And then there's some relative indications for starting antiretrovirals. Patients with Kaposi's sarcoma, most of them will actually respond beautifully to antiretrovirals unless there is visceral involvement. But the patients who have skin involvement, especially if there's not too much lymphatic damage, the lesions will pretty much melt away. So start them as quickly as you can. CNS lymphoma or other types of lymphoma do well on antiretrovirals in combination with other chemotherapeutic regimens, and herpetic whitlow also is a relative indication for starting heart. The one thing that we all need to look out for is iris, right? That immune response inflammatory syndrome, which is the immune system, which has been dormant, depleted, damaged, right? Just exited the whole scenario. So you're not getting much, cytokine production in your patients. You put them on heart, and all of a sudden the immune system wakes up, looks around, says, WTF, what's going on, right? And mounts this massive inflammatory response with fever and swollen lymph nodes. You have to be prepared for that. And that will happen especially in patients who have a really low T cell count. And for those patients, again, you have to be prepared to act, either to say, I'm going to tough it out, or I'm going to give them steroids to calm down the immune system, but not stopping the antiretrovirals. So as a quick summary, and this was a really nice slide that was summarized in the WHO, publication, because everyone will argue about this. I argue about this with my ID colleagues in the hospital, when to start heart. Well, everyone, as much as possible, should start it right away if there are no signs or symptoms of TB, right? If there is suspected TB, you start heart, but you haven't gotten the lab test back yet, you haven't gotten your sputums or your cultures, start heart. If it's not meningeal TB that you're suspecting or pleural TB, start it and follow up in a week in clinic, and then you can start, um, uh, the TB treatment at that point. If you have documented TB disease, right, then you start the TB treatment right away, right, inpatient or in the clinic, and you give them 2 weeks, and then you start heart. If they're diagnosed with TB meningitis, then there is a significant risk of iris in a closed space, right, which is in the brain, which is not good. And so you want to start the TB treatment first, including probably corticosteroids, as long as you can make sure there's no cryptococcus around too. And then you start heart 4 weeks after. Antiretrovirals started 4 weeks after you're diagnosed with TB meningitis. So 2 weeks after regular TB disease, 4 weeks after TB meningitis. For cryptococcal meningitis, 4 to 6 weeks after you start antifungal therapy. For histo, you can co-treat with heart and histoplasma treatment. And for KS, you should start heart right away alongside management of Kaposi's sarcoma, right? So again, it's nice to have the discussion, pull the individual studies and discuss it back and forth with your colleagues. But if you want to have a quick discussion as opposed to a lengthy one, pull out your WHO guidelines and say, okay, this is what the guidelines say. They're summarizing the evidence for us, and this is probably what we should do. A quick reminder about IRIS, inflammatory response immune syndrome. It operates in that setting where you have a very low T cell count, again, and a disseminated opportunistic infection without much response, right? The immune system can't respond. There's lots of antigen around, there's a lot of immune cell dysregulation, there's not much reaction to that antigen. But when you start antiretrovirals, and the time frame can be anywhere from 2 weeks to 2 years after, but usually it's within 2 weeks to 2 months, you get this massive cytokine activity production. You have localized edema, focal inflammation, fever, night sweats, right? And that's what's happening. And the trick there is, with this exuberant expression of the immune system that's woken up, do not start antiretroviral. Do not stop antiretrovirals. Don't do it, right? You treat through, if you need to, you squash the immune response with steroids, right? Until the whole thing kind of calms down. And if you don't need to use steroids, like it's a TB patient who's got some adenopathy and pleural effusions, then just give maybe Tylenol or something like that, without using steroids if you can avoid it. Here are the two big subsets of hearts, of iris that you might see. So one is a new opportunistic infection. You can see someone with PML here with plaques that you've newly diagnosed. All right. You started them on heart here in the blue arrow. They're doing well after antiretroviral initiation. And then all of a sudden, they have a seizure, or they get a new focal neurologic deficit. And you do another scan, and instead of one lesion, now you have three, right? Again, that's your nightmare for PML, and that's iris. And there in that setting, what you need to do is you don't have anything else to use, so you better continue with your antiretrovirals and you give steroids to calm the immune system, okay? Don't ditch the, antiretroviral therapy. It's not a failure of the antiretroviral therapy. It's just the immune system responding now to antigen that it had not been able to react to before. Now, you may also have another patient in the panel below who has no symptoms. You put them on heart, and in this patient, 4 or 5 months later, all of a sudden the immune system has recuperated enough that it's looking around and saying, oh, here's that visceral leishmaniasis that I did not recognize before. Let me go mount an intense inflammatory immune response to it. And now you're recognizing and unmasking a new OI diagnosis, right? So that's unmasking iris. And again, you want to try and treat through, and, add the treatment for visceral leishmaniasis, give steroids if you need to. And those are the cautions that we have to keep in mind. Of course, the packaging is important. Again, I'm coming back to my patient with, the difficulty swallowing. We're in week 2. I'm walking into a room after 8 days of being in the hospital. She still can't swallow. She's pissed, right? Upset because she's not getting better. And I tell her, look, I know what's wrong. I know what to do now. We're going to start you on steroids and you're going to start to feel better. But she's very upset, right? And now the medical students are looking at me, the residents looking at me because she's giving me the what so, right? So what do? Right? Don't engage, right? Don't sort of get triggered yourself, right? So we step out of the room. I call a social worker, I call one of the pharmacists, and I go back without the students and without the residents, and we'll have a little heart-to-heart talk about what's going on. I give her my card with my phone number. I don't do it all the time, but I did give this to this patient, and I say, listen, this is what we're gonna do. Here is your follow-up appointment. Look, we already booked you to come back and see me in clinic in 1 week. Here are the contacts for what to do if things don't get better. And here again, and this, you shouldn't always do this, but here is my absolute guarantee. In 2 days, you're going to be feeling like a new person and you're going to be eating and drinking and doing just fine. And thankfully it worked, right? Because if it didn't, I'd have been up the creek, but it did work. And 20 years later, she's still one of my patients that she comes and sees me. And she doesn't really use my telephone, my cell phone that often. She only calls or texts me when something really bad is happening. So it's not so bad, right? But again, you do need this package, right? Transitional care, support care to make sure that your patients continue to do well. There's a package of labs that are standardized that you should be ordering, including baseline viral load and T cells and resistance profiles and, cryptococcal antigen, and maybe, depending on where you live, but not for everybody, a urine or blood histoantigen. Making sure that you screen all your patients with pap smears, and or if you have the facility to follow up, to do anal pap smears, that you screen for other STDs, that you screen everyone for tuberculosis, and that you're looking for hepatitis, especially hepatitis B, but also Hep C, and depending on how ill your patients are, checking also for toxo titers. So the components of that WHO recommended screening process for advanced HIV disease package of care include those screening tests, especially for TB, cryptococcal disease, and nutritional deficits, right? You really want to make sure that once you screen for those things, you also have the capacity to act on it. If you find someone with a cryptococcal antigen that's positive, you need to treat them, right? You need to have the facility and the means to provide treatment. If you have someone who's got latent TB, you need to give them TB treatment, right, for latent disease, which can be anywhere from your standard 6 months to as short as a month, right, with some of the newer regimens. You need to put them on appropriate prophylaxis. And for anyone with advanced HIV, that includes prophylaxis against pneumocystis jirovecii. You need to start antiretroviral therapy, and you need to go through and make sure you have the facility to do GYN follow-up if needed, psychiatry follow-up and screening, pharmacy follow-up and counseling. So back to my 35-year-old woman with the acute retroviral syndrome, or rapid progressor, right? Doesn't really matter. She has one of the two, and we'll probably never know, who has idiopathic esophageal ulcers, and we started her on steroids. So this is her baseline T cell count, 340, viral load 1.4 million. We put her on Biktarvy after the steroids work. And again, thankfully, it was 2 days and she's doing great. Does she need PJP prophylaxis? If you have an opinion, put it in the chat. Does she need cryptococcal prophylaxis? What kind of virological response would you expect? Let me see if anyone put anything in the chat here. All right, so in the US, right, we would not give her PJP prophylaxis, right? Because the immune system, we would say, is probably still strong enough. If you look at the WHO recommendations, though, they say for advanced HIV, CD4 count less than 350, and she has advanced HIV, you should start PJP prophylaxis because there does seem to be a benefit in terms of outcomes. So it depends on where you practice, right? If you're practicing in, Trinidad and Tobago, and your clinical practice is much more like the US, then definitely, go with it. But if not, then you need to continue to watch her carefully and sort of, not worry too much. Does she need cryptococcal prophylaxis? Well, you would screen with a cryptococcal antigen and see if that's necessary or not. And if it comes back positive, then you probably need to treat her for cryptococcal disease, right? And what kind of virological response is expected? Well, would you say that the T cell count is the most important test obtained at 1 month after starting therapy? A follow-up viral load should be first checked 10 to 12 weeks after starting therapy. A follow-up viral load should be checked 2 to 4 weeks after starting therapy. Or a decrease in viral load from 1.4 million copies from baseline to 500,000 copies after 4 weeks indicates an excellent early response. So which of these is true? This should be like a snap answer for you guys because you're doing treatment for HIV all the time. And you know that this virological response is not what you want to see, right? You want to see at least a 1 log and mostly 2 log drop with most of the patients that we start therapy on. And you probably should check the viral load 2 to 4 weeks after starting therapy, right? So this is that classic response that you see very, very fast with HIV, within 2 to 4 weeks after starting therapy because the viral load will come down so quickly. And the T cell count response can be slower, right? If you're starting really low, it's going to be less than, and less robust. If you're starting, at a higher T cell count, then you may get a greater response. But in general, the CD4 response is about 100 over copies a year. Less if you're starting lower, and maybe more if you're starting higher. And we know again that after you start hard, depending on where you start, you will plateau eventually. All of my patients tell me they want to have T cell counts of, 1,000, and I have to kind of give them a reality check and say, if you go from 50 to 100, God bless. We're happy with that. Let's live with that. You're doing okay. So again, the WHO guidelines focus on this. All adults and adolescents with a T cell count less than 100 should be screened for cryptococcal antigen before ART initiation or reinitiation if they're lost to care, and consider for T cell counts less than 200. Again, we don't do this routinely in the US, and you have to look at your resources and your practice to see how much cryptococcal disease you're seeing to consider if you're going to do this, right? But if you're following WHO practice guidelines, then yes. WHO does not routinely recommend screening for histo, but again, if you're living in an endemic area, Central America, Southwestern United States, then, you certainly would want to screen for it. The Mississippi, Ohio River Valley. You can use rapid diagnostic tests to screen for TB disease. And again, Bactrim as prophylaxis, right? In the US, it's a T cell count of 200 or less, or any AIDS defining illness. But WHO says anyone with advanced HIV, like our patient, or a T cell count less than 350, should be started on PCP prophylaxis until their viral load suppressed. Some of the recommendations out there, they have some newer guidelines, and I'm going to wrap up quickly so we can get to our case. Newer guidelines for rapid treatment and prevention of latent TB, right? You may only be using your 6-month therapy of INH and B6, but again, you can get your patients through this as quickly as a month or 3 months with INH and rifampicin if you have it available. And then some new recommendations for treatment for KS are also out there. Paclitaxel or pegylated doxy for those with KS. Always, always, always those start heart. And you're going to distinguish between mild, moderate KS, depending on localization, versus severe. If it's in the lungs or the GI tract, then you need systemic chemo. Okay. It can be tricky, right? So here's an oral manifestation of Kaposi's. Here's someone else with this hyperpigmented macular lesion on the nose. And then here is a chest X-ray that shows significant adenopathy and paratracheal adenopathy in a patient with TB. So sometimes, again, those classic presentations are not as easy to pick up as we want. We have to have a high clinical suspicion. I think HIV practicing physicians, we know what to look for. Sometimes, again, the internists or the hospitalists may not be as familiar and look at this and chest X-ray and say, oh, it's a lymphoma or it's, something else. TB 1, 2, and 3 for an HIV patient with adenopathy. Hearts start early. You know what your antiretroviral regimens are that you should use. Initiate as soon as you can. Integrase inhibitors are the way to go. Integrase-based treatment nowadays, both in the US as well as WHO. But if you're not sure and you need to use a boosted PI, then using darunavir boosted is the way to go with WHO now. So Simtuza, if you have it available, or Norvir with darunavir is the way to go as your initial treatment regimen. I think I'm actually running low on time now, and I want to give us some time to get to our cases. So I'm going to stop here. Just make this our last slide. And again, just want to remind you that this is one of the reasons that we do HIV care, for me anyway. This is a patient who is co-infected with TB and HIV, who is been, hospitalized in the Central Plateau of Haiti. You can see him here with his mom, and that's that same patient 6 months later, right? And one of the things, again, I always remember and I always think about is the intervention here was not based on physicians. It was not based on having T cells or viral load. It was based on community health workers, right, that made that difference, who would go to that patient's bedside where they were living, monitor side effects, monitor adherence, and that's really what made the difference, right? So, it makes a difference, and this is one of the reasons that we do this and that we really enjoy doing this. So I'm going to stop there, and hopefully we get a chance to do our case.
Yeah, wonderful. Thank you so much, Dr. Stephen. That was very comprehensive. We did talk about a lot. I liked how you framed the case and you took us through. I think, though, while we're anxious to get to the case, I'll allow for maybe 5 minutes if there are any questions, if there are any comments for Dr. Stephen. Please go ahead, open your microphone, and you can make your intervention, or you can text using the chat. Yes, Dr. Omar?
Thank you very much. I just wanted to come up and say thank you very much, Stephen, for this very, very good presentation that really show the information, the whole recommendation, but much more than that, your expertise and years of caring for patients. I think that I wanted just to highlight in what you said about connecting with the patient, providing the cell phone, and making the arrangement plans before leaving the hospital, because it's where most of our patients fall in the crack. I mean, a bad experience in the first time, or the first time they were admitted, or the first time they were cared for, the discrimination in the health system, or this lack of feeling that they have somebody that care for them is one of the most common reason they say why they are not going back to the hospital. So thank you very much for highlighting that, and for your presentation.
You're very welcome. I saw and I agree with you completely. Connecting with your patient and making sure you're there to follow through with them is a huge, huge issue. One of the questions that came from Jeffrey Edwards, what does one consider rapid antiretroviral initiation? So we've really invested heavily in Miami-Dade County for the ones who arrive in clinic, test and treat. So within 1 to 2 hours after having a positive test, we are getting the medications dispensed from the pharmacy and getting the patient started same day. And in the hospital, again, the limitation is sometimes getting them connected to, you can start them on treatment in the hospital, but when they leave, if they don't have all the paperwork to connect to the national program and get the meds for month 2, that's where things can sometimes break down. If you have an insured patient, no problem. If you don't have if you don't have an insured patient and they need to go through your enrollment process, then it can be kind of difficult. But rapid antiretroviral initiation nowadays for us means same day therapy, in a practical sense. As soon as the test comes back positive, don't wait for them to think about if they want to start or when, get the meds dispensed and get the paperwork done and start them on treatment. So,
Yeah, thank you, Dr. Stephen. We'll take one more question from Dr. Tai, and I can ask Dr. Boyce to start putting up his slide.
Thank
Go
you,
ahead,
Dr.
Dr.
Symes. Thank you, Dr. Shanti.
Mhm.
I can tell you that I trained with Dr. Symes almost 20 years ago, and I learned everything about HIV care from in like the very early stages from Dr. Symes, and the same lessons hold true today. And the idea of having that initial presentation or connection with the patient still works today with my patients. In the Virgin Islands where we have those care teams, but they're usually armies of one. So when we always get down on ourselves thinking that, well, we don't have a lot of staff. Well, if you have passionate people that care about the patients and that will meet them and really connect with them on a heart-to-heart basis, they will come and they will always show up. So we have our linkage to care coordinator who sometimes sees the patient before me if they get diagnosed in the hospital, and they will always come back and say because of that connection they feel that they know that everything is going to be okay just because of that, that commitment and making sure that they have what they need in the beginning. We have one TB coordinator, so that TB person will see all the patients and she will do DOT, and it's that one person. So we get scared thinking that, oh well, if that one person isn't there, but we get through because then we cover for each other. But the patients always know and they feel that care with that one person, and then so we work together. So I think what Dr. Symes mentioned about making sure that getting to the patient and having that heart to heart really works when they make the connection and they see that you care, even when you don't have a lot of the bodies. It always works out if you show your compassion and you make certain that they know exactly how to stay within the system. The patients show up and you can provide the services even when you have very small teams. Thanks,
Yeah.
Dr. Symes.
Thank you,
Well
Dr.
said, Dr. Hunt, and that's why she's the leader that she is. So,
She absolutely is. Thank you, Dr. Tai. So certainly support systems are really very important. Before Dr. Boyce goes into the case study, let me tell you a little bit about Dr. Gregory Boyce. He's a physician and HIV clinical researcher and also the Deputy Director of the Medical Research Foundation of Trinidad and Tobago, MRFTT, the largest HIV STI center in Trinidad, actually. As Deputy Director of MRFTT, Dr. Boyce is part of the leadership team that is guiding the institution in relation to HIV treatment, prevention, research, and public health initiatives, really leading Trinidad and Tobago's response. Dr. Boyce is very much involved in research as well and has contributed through publications to several important areas of HIV care, and including retention in care, patient tracing tracking programs, HIV drug resistance, PMTCT, long-term outcomes of HIV, and many more. And so this afternoon, Dr. Boyce will share with us a case that he's currently managing. And so I will hand it over to you now, Dr. Boyce.
Hi, good day, and thank you, Shanti, for that generous introduction. Can everyone hear me clearly? All right.
Yes,
So thank you. So this is a case actually that's really quite interesting because it's a very current case. So this is a case of a 47-year-old heterosexual male who presented to us just about a month ago, along with his partner, after both had tested HIV positive at a private clinic the previous day. He had decided to be tested for HIV after he learned recently that his prior partner had died from a complication of advanced HIV several months ago. At the time of presentation, he had complained of fever, cough, anorexia, and weight loss. He says about 30 kilograms, which is quite significant over the previous 2 months. He was employed in boating industry and he had daily exposure to birds and bird droppings, but he denied any recent TB exposure or recent sick contacts. The physician who examined him already documented that he had no abnormal physical findings other than the evidence of weight loss. So baseline blood investigations were requested along with a chest x-ray. And antiretroviral treatment was commenced with emtricitabine, tenofovir, efavirenz. Just a note on the regimen, we do not have access to dolutegravir as yet. The patent will have expired at the end of last month. So the government is now working to see if we can actually get access to generic dolutegravir so we can put our patients on it. So the baseline CD4 count was less than 200 cells. This was with a semi-quantitative device called a Visitec CD4 Advanced HIV Advanced Disease Rapid Test. Essentially, just lets us know it's a blood test that lets us know whether a patient's CD4s are below or above 200. It doesn't give us anything more specific than that. But its baseline viral load was just over 1 million. In terms of other blood investigations, the renal function was fine. The liver enzymes were a little bit elevated, about just about 2 times upper limit of normal of both AST and ALT. White count just below 3, 2.5, hemoglobin of 125, platelets 151. Now he would have started medication on the day of presentation on the 14th, but he was admitted to hospital shortly thereafter, complaining of painless, frank hematuria for just about a day. He denied fever, chills, abdominal pain, bleeding on urination, urgency or urgent incontinence. When he was examined, he was found to have mildly tender, smooth hepatomegaly, so liver edge was just about 6 centimeters below the costal margin. Blood pressure was 106/85. He was tachycardic at 102. Had a fever of 38.3 Celsius, but his saturations were 96% on room air. A CT was requested, which was done the same day and showed a non-obstructing sub-centimeter, there's about 3 millimeter left renal calculus. The kidneys were otherwise unremarkable. There were CT features suggestive of an acalculous cholecystitis, so inflammation of the gallbladder without a gallstone. He had multiple mesenteric lymph nodes and multiple pulmonary nodules on the the part of the lung that was captured in the CT, with some associated hepatosplenomegaly, which in the background of the patient history may represent, sorry, a mild proliferative disorder or some other neoplastic process. I mean, given that CT report, I'm not certain that the radiologist was informed that this was someone with advanced HIV, because I suspect a different differential might have been generated. And the recommendation was that clinical and hematological correlation was advised. A chest X-ray was performed, which shows some perihilar and lower zone nodules bilaterally. By the time of admission, liver enzymes had worsened. His AST was now 254, which is about 6 times upper limit of normal. ALT was at 116, about 3 times upper limit of normal. Creatinine was still normal at 0.9. We obtained for the first time his alkaline phosphatase and gamma glutamyl transferase, both of which were significantly elevated. His white count was about 3, hemoglobin 12.9, platelets 102. As coagulation screen was just a little delayed, but not significantly so. This is a picture of what his chest X-ray looked like. I'm not sure if you can see it on the screen, but you can see sort of fine nodule infiltrates bilaterally across both lungs. I'll leave it up for a second and I'll go on. Urine microscopy and culture was done to try to evaluate the cause of the hematuria. Numerous red blood cells were seen, very few white blood cells, 2+ albumin, some coarse granular cast, but no bacterial growth. In terms of his trying to figure out why liver enzymes were deranged, hepatitis C was negative, hepatitis B is still pending, and HLV1 was negative. The primary team, based on his clinical findings and what the CT reported, did request a TB quantiferin assay. At MRF, when we reviewed him, given the frequency of histoplasmosis in Trinidad, also recommended a serum or urine histoplasma antigen and a urine TB-LAM assay. On the advice of his surgical team, he started ceftriaxone and metronidazole for his cholecystitis, and cotrimoxazole was added for PgDip prophylaxis. And a formal CT chest was requested. So the report on the chest, which was done just a couple of days later, showed innumerable tiny foci in train but apparent throughout both lungs with small focal opacities, predominantly at the apices, suggestive of early granular matters formation, highly suspicious familiary TB. There was also significant extensive mesenteric lymphadenopathy, with the largest up to 1.7 centimeters, with areas of central hypoenhancement suggestive of necrosis. There was some matted paraortic lymph nodes with no significant pelvic lymph nodes noted. In the opinion of the radiologist, the pulmonary features were suggestive of an infective or inflammatory process. Consider pulmonary TB, fungal infection, or possible miliary metastasis. And the hepatosplenomegaly with extensive mesenteric and retroperitoneal lymphadenopathy, they thought were also in keeping with miliary TB, but also said that a myeloproliferative disorder or fungal etiology could not be ruled out. So, sorry. on the basis of, the frequency of, again, histoplasmosis, and we decided to start him on empiric antifungal treatment with oral itraconazole. His regimen was switched to raltegravir-based regimen due to the interaction with efavirenz and itraconazole. The National TB Program were contacted for their advice and initially recommended initiation of anti-TB treatments and transfer to the thoracic ward or the TB hospital. But on further review of the TB finding, of the CT findings, and in particular because of the extent of intra-abdominal adenopathy, they decided to reverse that decision and thought that lymphoma should be investigated before any consideration of TB treatment initiated. And the hematology team, they decided to do a bone marrow aspirate to investigate his pancytopenia. Unfortunately, the patient could not afford the TB LAM assay or the TB quantiferin because it's not available in the public sector at this time. The sputum acid fast were negative, the PCR is pending, but it was noted that sputum saline induction had to be performed because the cough had completely disappeared by the time he was hospitalized. And microbacterial cultures, including cultures from Mycobacterium avium complex, are unavailable. He identifies previous spotter during hospitalization. He claims to have separated from her in 2023. And when we did an investigation, we realized that she had actually come to see us in 2025, having been diagnosed in 2014 and lost a follow-up subsequently. And there was a suggestion by the treatment site that we further test she was on an efavirenz-based regimen. Her most recent viral lows in 2023 all over 100,000 before she transferred to MRF in 2025. And unfortunately, she passed away in 2025 from a suspected lymphoproliferative disorder. That's all the detail we can get. And of importance, the patient's partner, who initially tested HIV positive at the private clinic, her repeat HIV rapid test and ELISA were both negative. So in summary, we have a 47-year-old newly diagnosed heterosexual male with a history of anorexia, weight loss, and fever and cough, antiretroviral therapy was commenced on the first day of presentation with an efavirenz-based regimen. He had advanced disease with a CD4 less than 200, a viral load over 1 million, but presented a week later with painless hematuria, hepatomegaly, and pancytopenia. The CT abdomen, pelvis, and chest suggests a calculus cholecystitis, possible miliary tuberculosis with a differential diagnosis of a fungal or mild proliferative cause. He has commenced empiric treatment for disseminated histoplasmosis with oral itraconazole, and his antiretroviral therapy was switched to a raltegravir-containing regimen. It is noted that his past partner had a history of poor adherence to ART on an efavirenz-based regimen. So the question to the community and the expert panel, and we're desperately short on time, should his ART regimen be switched to a boosted PI regimen in light of his partner's past treatment history and the risk of transmitted drug resistance? Is there sufficient evidence of histoplasmosis to consider intensification of antifungal treatment with amphotericin B? Unfortunately, all we have access to is deoxycholate, not liposomal, and disseminated MAC infection, a possible diagnosis in this case. So I will leave it there. That's the end of the case. So I open it up with clarifying questions or comments from the
Yes.
community.
Go ahead, Dr. Stephen.
Yeah, so I would say that you will know in 2 weeks, right? 2 to 3 weeks with a repeat viral load if the medication's working. So I think you could take some solace with that. And right now you have him on an integrase-based regimen, right?
Yes.
The big concern is maybe there may be NNRTI resistance. It's interesting when you look at this whole idea of transmission of resistance. Yeah, his partner, right? On her milieu, her pool of HIV, she may have had some resistant strains, but that doesn't necessarily mean that she would have transmitted a resistant strain to him, right? So that's what I would do rather than trying to chase your tail about trying to get, resistance profiles, which you'd have to do after 2 weeks anyway. Just repeat the viral load after 2 weeks. If you see a nice drop in the log, viral load log, then you're on the right track. If you don't, then I would go with the darunavir-based regimen if you have it available, right? So I think that can answer your question very, very quickly. In terms of MAC, when you you told me about the abdominal CT, right? That's almost the first thing I thought about. in the US where we have um, or
Yeah.
we used to have a lot more MAC than TB.
Mhm.
But globally, again, the burden of this adenopathy with the necrotic center is much more likely to be Mycobacterium TB than it is MAC. And MAC is a disappearing disease. So I think you still have to have that high on your differential. Um, and I think you're still trying to figure out, is this histo or TB, right? Ultimately. And there's always this danger of trying to think about escalating disease without the right microbiological diagnosis and sensitivity. So, not sure if you could beg, borrow, or steal TB PCR from someone, right? And or histoantigen, right, in the serum. I think those would be really, really, and maybe just a cryptococcal antigen just as a plus too, with the WHO guidelines. But those are the things I might try and do if available. So,
Any comments from you, Dr. Boyce? We have Dr. Omar's hand is up. You can keep your microphone open, Dr. Boyce, so that we can have this
Right.
conversation.
But so that is the difficulty that we are running into. That so we do have PCR available, but it might take about 2 weeks to get it back. That's at least the rough turnaround time. There was some challenge getting some sputum from him because by the time he got to hospital, the cough that he had initially complained of at presentation completely disappeared. So they did do some saline induction. They got some sputum, so they will send a sample off. In terms of the other testing, histoplasma antigen and everything else, because they significantly can't bear the cost, we have to be trying to see if we can find some other mechanism by which we can get access to it. But the challenge is it's not done in Trinidad. It has to be sent away and we get the result back again, 2 to 3 weeks. So we were concerned about the time for turnaround, given that he's back in hospital, he's throwing some temperature 38, 39, he's becoming a bit ill, and we're kind of concerned about do we have 2 weeks to spare? That's what we're worried about with him.
Yeah, very interesting case. Dr. Omar?
Thank you very much for the case, incredible case, and difficult situation and difficult context. Trinidad is the only country in the Caribbean that cannot use dolutegravir because patent, but they cannot use raltegravir also. So I mean, in generic we are talking about. So if this patient was switched to raltegravir because um, they couldn't tolerate or efavirenz, probably the best thing to do was to switch to dolutegravir that maybe has the same price, original, and is easier and more effective. But the clinic for this patient is really, really very difficult to say if it's TB or histo. I mean, the Trinidad has demonstrated high prevalence of histo. The patient has epidemiology and the clinical features like the anemia, the cholestatic pattern, the miliar dissemination in the lung, and the adenopathies can be both for TB, disseminated TB or histo. I really don't. I agree that Mycobacterium avium complex can be a potential, but it's much more frequent TB and histo in this context. Regarding to I would not, if the patient is with raltegravir, I will not change that to PI. If you want to change to dolutegravir if it's cheaper because it's once a day, or Biktarvy, but not to boosted PI because you will have more complication with the potential treatment for TB if it's confirmed or not. There is no sufficient evidence for histoplasmosis to decide on the change to amphotericin, but probably for this patient with this cholestatic pattern, and given that itraconazole is something that it really has a significant toxicity, it's probably for this patient better to be in amphotericin if you are suspecting. But it's an urgency to do the antigen. The antigen should be available. I mean, it's $5 the ELISA, $10 the Miravista, and PAHO can support the country to have access to that. The same for the LAM. The LAM is $4, and PAHO is in the PAHO catalog also, and they could offer access to that. And also the expert. I mean, the expert, the LAM, the crypto, the ISTO, and the expert, everything is affordable and should be the result in less than 2 hours. So it's an urgency to really have this in the country and hope this webinar create advocacy for that. But I will try, I mean, if I would, if there are other ways to do ISTO if you don't have access to the antigen, the culture is the saponin blood culture is cheap, but take 3 4 weeks to do. Uh, the direct examination, if you have any ulcer, any skin lesion, you can sometimes have some scarification and direct examination with HEMSA, and you can see the histo there if there is a good experience. So will you figure out how to have access to this antigen? Um, and then the decision of the problem will be with the itraconazole. I mean, if there is a decision to start treatment for TB, there will be a necessary to use amphotericin because the interaction with itraconazole is so severe that will really not be possible to do together. I don't see this patient have lymphoma, as they say in the clinic, in the TB clinic. Really, I think that most this bone marrow affectation is histoplasmosis. Thank you. Over.
Very good.
Yeah,
Thank you.
thank you, Dr.
Thank
Smith.
you, Omar. I saw Dr. Davy, you had your hand up. Do you still want to speak? Okay.
Hi. Hello, Dr. Shanti. How are you?
Hi,
Yes,
Dr.
I think I missed some of the case. Was an AFB done?
Yes, so it was done. The AFBs were negative. The PCR is
Okay.
pending.
Okay. Right. Because then you would really be able to differentiate. Well, with the AFB negative, more than likely MAC would have stayed positive for you. So maybe you should move on to another diagnosis because MAC and TB would stain positive for you.
Mhm. Yeah.
Yeah.
Well,
But
let's
it's
see.
very difficult to get data or or like reliable like diagnosis without biopsy familiarity TB. Sometimes you might not have the sputum. The sputum might not give you the answer. So I'm worried that there
Yeah.
needs to be, an intensification of trying to like diagnose this patient that I'm thinking that will have to be some sort of like biopsy.
Yeah.
This happens to me all the time, like where I'm struggling with trying to diagnose, and thinking about all of the different things, and I'm with the pulmonologist, who's always telling me, no, we're not gonna, I'm always saying like, should I also just add this for Mac? And she's like, no, no, let's make sure to let's diagnose, and then I'm like, you're right, let's diagnose. So it has to be, you need to
Yeah.
treat, what you think is you got to use your gut to think, what it is now to, what's the most likely diagnosis, and then really, really push to get some sort of diagnostic capacity. And I'm thinking that this would have to be some sort of biopsy
Yeah.
or
The hematologists are supposed to have been doing the bone marrow biopsy this week.
I
So I'm
think
hoping
that
they'll
that
do
would be
fungal stains,
most helpful.
they'll do some.
Absolutely.
I think that'll once that's done, I think hopefully that'll clinch the diagnosis for us because I saw there was a question in the chat about a lymph node biopsy. He has no peripheral node. When I say no, he has like one node about a centimeter across this left axilla. He has no other accessible peripheral adenopathy. So that was kind of a bummer because we would have hoped to get. He has no skin lesions, he has nothing. So the bone marrow is sort of the what we're putting our hopes on right now.
I think that's where your hope would lie. And that's what I would do too. And that's what I usually do, try to do.
Yeah.
The bone marrow will give you with the stains and stuff like that will give you some sort of idea as to what the best thing is. I'm cringing thinking that you want to start treatment with amphotericin B, with all of the what could happen, and this isn't, histo.
Yeah.
So, it's like
It-
excellent.
it's we have the same cringe reaction. It's like the only time we start amphotericin is when we're sure of the diagnosis or
Correct.
when the person is so sick, look, we have to try something because this person is deteriorating fast and we don't have time to wait on confirmation.
I
Because yeah,
support that.
we've been burned with amphotericin so many times.
I support that.
Yeah,
Yeah. Well, good luck. This is an excellent case. I hope the patient does well.
sure. I hope so too. I hope so too.
Yeah.
But thanks so much. I appreciate so much all your input.
Thank you, Dr. Boyce. Quite a very interesting and complex case. And as Dr. Hunt says, good luck with the case. Dr. Omar did make a point about access to some of the point of care testing for histo and for crypto and so on. And I think that, as he said, here is an opportunity for us to advocate so that we can have those in our programs. They're accessible. I think that they are on the PAHO Strategic Fund. So let's think about them in our programs. And as you said, on the good news front, Dr. Boyce, you now within the next month should be able to have access to dolutegravir and some of the other INSTI. So with that, colleagues, I want to thank Dr. Stephen for an excellent, excellent presentation and Dr. Boyce for really bringing to us a very complex and interesting case to complement the discussion on adult and on advanced HIV disease. I want to thank Dr. Tai, Dr. Umar, and all of the members of the Caribbean Community of Practice, the advisory group to the COP that are here with us. And thank you, colleagues, for joining and for participating in the discussion. Do look out we have the post-test that's up. I think that's the pre-test mark, but go ahead, start responding to the questions, to the post-test. And I do look forward to seeing you at our next session. You will get the announcement, which should be coming out shortly. If you do have any case that you will need to get some advice on, to consult on, or it's just an interesting case that you'd want to share with us, please feel free to send me an email and we can always schedule those cases for our upcoming community of practice sessions. And so with that, again, you will receive an exit survey to share with us what his experience has been like. And secondly, we will send the PowerPoint presentations to you in an email very shortly. Please continue to respond to the poll. And ladies and gentlemen, colleagues, thank you for all being here. Thank you, Dr. Stephen. Thank you, Dr. Boyce. Thanks, everyone, and do have a good rest of the day.